Thank you very much, and it's an honor to be here. And so I will talk about neuroplasticity, or how your brain changes after ACL injury. And I'd really like to thank Kinsport and the organizers for putting this on. This has been a really great symposium so far, and it's really a privilege to be here. And I have no conflicts of interest, so I do have funding from our federal government, from the National Institute of Health, and our university and the hospital, but I have no products or consulting or any conflicts. What I'll talk briefly about neuroimaging, neuroplasticity, basically how we capture brain changes. I'll talk about how ACL injury can induce this neuroplasticity, and then about ways your therapy can address these brain changes. So the first thing I want you to think about is I want you to recontextualize or rethink how the ACL injury event fundamentally happens. So what you're going to see is a series of videos of all these people experiencing non-contact injuries. And a key observation from all of these injuries is that they almost never happen in an isolated environment. And what I mean by that, there are several papers that looked at video analysis of injury events. And what they see is that up to 80 to 90% of these injuries occur when the person is cognitively distracted, when there's something else going on in the environment. They're not just staring at their knee land as we test in the lab and as we test in the clinic. They're commonly engaged in a very complex situation. And so I would argue this is your first clue that these injuries are much more complicated than simple biomechanical structural injuries we typically think of them as we think of them in orthopedics. And I would argue it's a sensory motor mismatch. So before the injury event even occurs, the neural activity that results in that knee valgus has already happened. And I'll show you some data to support this idea in the middle of the talk here. Your next clue that ACL injury is far more than just a structural or biomechanical problem is what we call arthrogenic muscle inhibition. That's what you're seeing on the top. Someone has a joint injury and the muscle neurologically shuts down. So it has nothing to do with the muscle. The muscle's perfectly fine. But this ligament injury causes the muscle to no longer be able to fire, even though the muscle is totally fine. So this is your second clue. First, the injury event happens secondary to a motor coordination error. And now after the injury, we have a muscle change that has nothing to do with the muscle. It's entirely neurological. And then I will argue that we need to start thinking about this how we approach our therapy. I really think physiotherapists, athletic trainers, coaches, you're much more powerful than you realize you are based on what you say, and how you give your feedback for your exercises can drastically change how the brain will activate, and that can set your patient up to have more success. Typically, our field has used primarily biomechanics, and it's an exceptional tool. We had two great talks earlier today that dived into biomechanics, and it's a tool that I commonly use. And it's been wonderful over the past 30 years. This tool has told us what are the risk factors for injury? What is the best surgery to do? What are the muscle dynamic and kinematic changes after an injury? However, reliance on just biomechanics has left us with up to a 30% re-injury rate in those that want to go back to high-level sports. And it takes 9 months to 2 years to recover a lot of the deficits we see. And I think most of us, what I've gathered is most of us are rehab clinicians or physios here. This is the hardest job because you are with the patient the longest. And for you to put your heart and soul into them and work with them for months on end, to have them re-injure is truly heartbreaking. And so this has propelled our lab where we try to better understand how the nervous system is generating those movements to see if we can't optimize therapy in some way. So there's an immense amount of neural computation that occurs that we have traditionally left out of our orthopedic approach. For instance, all of you right now are sitting upright. You're able to hold your head up and you're tracking me with your eyes as I walk across. So every second, just your cerebellum undergoes anywhere from 100,000 to 1 million neural computations every second just to do what you're doing now, and you're basically doing nothing. So this massive amount of neural computation we essentially leave out of how we generate movement, but that is certainly something that changes after even an orthopedic injury. So before I get into how the brain is changing, I just want to briefly overview in a very simplistic way how we generate motor control. So one of the first steps is you pull information from your entire brain. So a lot of people, or it used to be thought of that the brain was highly localized, that you had your motor region, your sensory region, your visual region. It's actually not the case. The brain is much more a network than it is a localized processing unit. So what happens is you pull information from your entire cortex when you go to move. This is because how you generate motor memories are not isolated to just the motor or sensory cortex. What you're seeing, feeling, even what you're thinking about, smelling even, all play a role and all get encoded in the same way when you're learning a new movement. And so if you don't take anything from this lecture, think about this step. Does your clinic, when you're doing a straight leg raise, look like what they're going to have to do on the field? So you are generating a motor pattern to increase quad activity, but you're doing it in a way that does not take advantage of all this processing that has to happen when they return to their sport. This is why we see impaired muscle activation as you add complexity to a task. And then all that information gets encoded in your premotor cortex, motor cortex, and down to the muscles. But again, this step is very important. This is a huge opportunity to intervene in how people are generating and creating their motor memories in their therapy, which is essentially what you're doing with your therapy. You're trying to retrain or generate new motor memories, and that could be as simple as just increasing quadriceps activity. So in our lab, we primarily use this tool called Neuro Imaging or brain imaging, mostly because it's one of our best tools to measure the human in vivo or with the living human. If you want to do other experiments, you can get much better resolution, but a lot of times this is what we're limited to in human clinical studies. And it's a powerful technique because we can map the whole brain, but a negative of it is if you want to study sensory motor control, this is about all you can do for now. So we've gone and instrumented this with force dynamometers and MRI safe kinematics, so we can measure this movement. But to get someone to do this movement, it took about a year to figure out. So if you come and do one of my studies, you get strapped in the MRI, and we have this specialized head foam that explodes all around your head in the coil, and you can't get out of the MRI without someone to help you. So you are strapped in, and it's a pretty intense process. So you can't be claustrophobic at all, because if your head moves any more than about 0.5 millimeter, then we can't use the data. So it's very hard to keep your head stable and do lower extremity movement. But what we're able to do is we're able to capture the brain activity of when you're doing this movement. So we get an idea of how does your brain turn on to do that very simple movement. And then we subtract out your brain activity at rest. So all of us are, even though you're at rest, you still have a lot of neural activity. And we're trying to isolate what is the brain activation pattern to engage in this simple quadriceps dominant knee flexion extension task. And the next video I'm going to show, in red is if you've torn your ACL, this is how your brain activates, and in blue is if you're a healthy control. So I'll let it play a time or two. And it's blurry because we collect the data very rapidly. So a lot of times you're used to looking at MRIs that are very high resolution, high detailed. So this is sort of like the raw data coming off the scanner. And what you'll see is that there's a lot more red than there is blue. You don't even really have to run the statistics on it. You can see the ACL people activate a lot more of their brain and a lot of other regions to do this very simple motor task. And I was actually surprised by this, because for this study, we went through a lot of pain to match all our subjects. So if we had a collegiate level football player or soccer player, we matched them to a teammate on the same team. So a lot of work went into trying to find very tight controls, and they still had this much of a difference in neural activity. And there are a few regions that were the most pronounced in this analysis. So the first region that activated the most in the ACL group relative to controls was this area in your occipital cortex called your lingual gyrus. So what the lingual gyrus does, it's a cross-modal region. Now what that means is it tries to match two sensory modalities. So you have vision and you have proprioception or sensory feedback. What the lingual gyrus tries to do, it tries to match the two together. So if any of you have anything in front of you, if you reach out for it, And once you touch the object in front of you, your lingual gyrus goes, good, it's where I see it and where I feel it. So lingual gyrus tries to match the two senses. Now, if you have damage to one or the other, the lingual gyrus increases activity to try to use the other modality to compensate. So it's essentially a neural compensation region. So what we think is happening after the injury, you have impaired proprioception from the lost ligament. And so now your brain is reweighting to use visual processing as opposed to proprioceptive processing to engage in knee movement. Second area that activated more was the secondary sensory area. This area primarily processes pain, the posterior part that we found to be increased activity. All the patients in this study were 6 months or more from their injury. They were all returned to their sport. So I was very interested in the athletes. I don't care about the athletes that look terrible and don't return. I was more concerned about the athletes that I work very hard to rehab and they go back to play and some get re-injured. What are we missing in those patients? And so these weren't patients who were in any pain, but their brain still activates as if they are in pain. And so this can shut down some of your normal sensory motor processing. The other area that activated more was their contralateral sensory motor cortex. So these were all left injured ACLs. And so their right sensory motor cortex had to activate more. And this sort of corresponds with what we see in the other neuroscience literature looking at spinal cord and cortical excitability. Those studies show that the way the quad shuts down, you have to override that. You have to generate more action potentials to the quadriceps that come from the motor cortex. The negative of this is you only have so many neurons dedicated to the quadriceps in the motor cortex. And so if you already have to activate more to do a very simple movement, you lose capacity to handle more complexity. And so that's why coordination starts to break down as you add more aggressive maneuvers. One of the areas that activated less was the cerebellum, particularly the vermis. And what this area does, it allows you to do automatic error corrections. So if you're ever walking down the sidewalk or walking down the stairs, and maybe your ankle inverts a little bit, but then you save it, that is this region of the cerebellum is what allowed you to have that reflex and immediately correct for the sensory error. And so what we see is those after an ACL injury, they've traded automatic motor coordination corrections from the cerebellum for cortically driven, conscious, focused corrections, which are much, much slower. And then in a follow-up study, we isolated what is the region of the brain that results in impaired patient outcomes. So this was for the IKDC scores. This is how well your patients are doing. What we found, those with decreased outcomes, or those that reported more pain, more subjective discomfort, they had increased activation of this middle frontal gyrus, which indicates that they are relying much more on cognitive control of their knee. They haven't restored their implicit or their more automatic processing. So what we see after these injuries, we see this impairment in sensory cortex, which results in the brain to pull from other areas that it normally doesn't have to for knee motor control, mainly the visual cortex and the frontal cortex. And then in one final, this is a very recent study, this paper's still in review, we looked at diffusion tensor imaging. There was a great talk earlier about the backgrounds of diffusion tensor imaging. I don't know if he's here. But we used it in the brain, and what this allows us to do is map the very structure of the brain and see how it's connected. And what you can see is, we asked this question, show me where in the brain the knee area of the motor cortex is connected to structurally. So what you're seeing on your left here is just a rendering or a video representation of what this modality measures. So it measures water diffusion, and we can track the diffusion and see how things are connected. So what we found was, if you've torn your ACL and we look at your knee motor cortex, which is right at the top of the brain, the knee motor cortex is much more connected to lateral, temporal, and the other side. So it's essentially reaching in to the rest of the brain to pull in information because it's lost what it expects proprioceptive-wise. Maybe. The buttons aren't working. Try now. So the next slide is going to be about what about before the injury? So if we look at before the injury happens, is there anything we can see? So earlier I talked about that this is a sensory motor mismatch is responsible for the injury. And so we took advantage of some functional connectivity. So before that was the brain structure. This is how the brain's communicating with each other. And what you're seeing up here is this is how your brain's communication changes over life. Each dot is a brain region, and then each cluster is a network of regions. And as you see over the course of your life, this was an amazing study all the way from 8 years old to 80. And as you get older, your network becomes closer and closer together. So the distance between those regions tells you how well those regions are communicating with each other. The closer together, the more communication they have, the further away, the less they have. And as you age, you get more and more and more refinement of your network. And so we use this technology from a concussion cohort. So we had this massive amount of concussion data of people who were scanned before the season. And we asked this question, well, is there anything in this brain connectivity data that was different between those that went on to ACL injury versus those who did not? And we found one key connection was disrupted in those that went on to ACL injury, and it was this connection between the sensory cortex and the cerebellum. Now, what this pathway does, it basically allows you to correct for sensory errors. So what happens is the ACL patients, we think they are unable to make these automatic sensory correction errors. And so the obvious question is, well, what do we do? So you have all this neuroscience data. How do we change our therapy? So this is the most important part. And then I don't have time to go through everything we've been doing. If you do, my email's at the end. I'll send you the slides. If you don't take pictures, you can if you want. But I'll send you the slides if you email me, or some of the other therapies we've been working on. And so the first thing to think about is think about how you employ vision in the clinic, and then how we employ vision in the real world. So this is a good friend of mine, John, did this study. He was interested in ecologically valid biomechanics. And so he instrumented people and had them just walk, just hike, a normal hike, not fast, nothing crazy. And what I want you to notice is, up here is the eye tracking. This is their biomechanics. Just watch where their eyes are tracking. And so you'll notice that they only look at their feet. It's about 50 milliseconds during this whole time. So virtually never do they track their foot position. Vision is used to determine where you're going to be 2 to 3 steps ahead. Now think about what you do in the clinic. In the clinic, our first exercise is So our first exercise tends to be this. We allow them to stare at their knee and try to make a quadriceps. And so what most people do, they actually look at their knee probably more than they will their entire life in that first month of physical therapy. And we published this paper a few years ago, and my original hypothesis when I started this research almost a decade ago now was that I thought the injury was causing a lot of these neural activity differences. Like I thought, well, you lost a ligament, you lost mechanoreceptors, that's why the brain is changing in this way. And we have this ongoing longitudinal study where we're tracking people over therapy, and it's actually looking like our therapy is causing most of this. And I think it's because it's how we prescribe our basic exercises. So a lot of what I'll talk about in the next few slides is concerned about how do you tweak what you're already doing just slightly, because you still must recover movement and strength and range of motion and reduce pain. But if you can do it in just a slightly different way, you can avoid this whole complication. And so one of our studies that we use virtual reality. And so this is an example of trying to take the drop jump that we use a lot of, and we try to apply it in sports. So this is with Cincinnati Children's Hospital, where we've collaborated to try to figure out what is the neural activation pattern that allows someone to move well here. So it can be very difficult. However, Dr. Franklin Miller is working on in-field tests. We've sort of gone the other way, and we just brought the field into the lab. So you can try to bring the lab to the field. We're trying to test people in an ecologically valid sport environment because we are interested in people moving better here, not moving better just for your drop jump. We want them to move well in sport. And so we've been able to isolate the brain activation pattern that's associated with improved movement in this complex virtual reality world with a lot of sport engagement. And the only two things from this is that they need to have increased motor cortex efficiency. So that means decreased motor cortex activity. That allows them to handle more complexity. And then we want increased sensory region activity. And that's that increase in sensory integration activity that allows the motor cortex to not have to work as hard. And so Dr. Ali Gokler will talk more about motor learning in his next talk, but I'll briefly go over some of our data with it. Normally we think about controlling knee position like this, keep your knees over your toes. And we give what's called internal explicit feedback. This is how I was trained to give feedback. You tell people exactly how you want them to move, and then that's how they do it. However, that's not how you naturally move. If any of you have children, if they're like 5 years old starting to run around, ask them, how do you walk? None of them will go, well, I go hip flexion, knee extension, and then I go into dorsiflexion, plantar flexion, and I swing through. No one tells you. No one will say that. But if you go to a gait retraining clinic, especially in neurologic populations, they'll be like, extend your hip more, dorsiflex more. They'll tell you exactly what they want you to do. Now, the neural activation pattern to learn something explicitly when you know exactly what to do versus how we typically learn motor skills is implicitly. So typically the child learns to move just by doing it, and they can't tell you exactly how they do it. Now, in therapy, we do the opposite. So the question is, how do I induce implicit learning? So that's what this technology is for. This uses augmented reality, and so the patient can still see the environment, and we give them feedback on how they're moving. And so this uses 3D biomechanics, and then what the individual will see on the HoloLens, on the augmented reality, is this rectangle. And they're told, make this a perfect rectangle. They don't get told how the rectangle's changing, they just know it's changing. Now, we program the rectangle to change on knee valgus, on asymmetry. So if it goes into valgus, the rectangle pinches in. If there's a loading asymmetry, they load one side more than the other, it shifts and becomes more like a trapezoid. And you can change the shape however you want. And at the end of therapy, they can't tell you how they're moving. They're just trying to keep the rectangle a rectangle. And so you're obviously going to ask, this is great, but I can't implement this because this is multi-million-dollar research enterprise yet. Now, when Dr. Flink and Miller, when their equipment becomes available with XSINs, you can use that as a biofeedback tool. And the hope is you could implement this clinically. But until then, we did a small pilot study where you get some of the neural correlates, a very simple approach. And this should be the goal for all of your patients. So the approach is simply, so most of you progress your patients with resistance training, like you'll give them more weight, more reps. Well, you need to think of motor learning as a progression. So you want to get your patients to a level where you just say good movement or bad movement. You don't want them to be able to tell you all the things you're looking at and cueing on. So don't start with this. Don't open up your next clinic day and just stare at your patient and say, that's bad, that's good. You have to progress them to it, but this would be your goal. You want them to be able to move and not be able to describe to you how they're preventing injury risk biomechanics. Another way to bridge this, and I think Dr. Gokler will talk more about this, is use external focus, where you take the attention and put it on the environment. This gives you most of the sensory integration neural activity that supports motor learning. So this is basically using the environment as the cue. So instead of bend your knees more, you would say, bend your knees to a cone or to an objective. You can also use clinical virtual reality. So a lot of people always complain that VR is very expensive. We've done a lot of studies now where you just use your smartphone. And we use all the free apps. And we have a Google Doc for public access. I'll email you the link if you're interested. That has everything we've tried in the lab. And so what's great, these entertainment companies build all these tools, and we just use them for therapy. So for instance, this lady is doing her straight leg raises. This video is someone kicking a soccer ball from the first person perspective. And every time the person kicks the ball, she does her straight leg raise. So this has a lot of advantages. They can't see their knee. That's great. They're immersed in the world of soccer. Also great. And they get a little more enjoyment than just doing the boring exercise. This is another study that we finished that uses a roller coaster. And now we've adapted the roller coaster. So the roller coaster goes faster as they are more stable. So if the headset's moving a lot, the roller coaster goes slower. If the headset moves a little bit, the roller coaster goes faster. And so this is a way to progress balance training. One other tool that we've explored is to use stroboscopic glasses. So these are a tool that allows you to knock down visual feedback. So these are about $200. There's a bunch of companies that make them. What they essentially allow you to do, they allow you to dictate the level of visual feedback you're receiving, and you can customize it to be any frame rate you want. So why this is good is so you can add a layer of visual disruption to your training, and you can progress it. That's the most important phase. You can go from very slow shutter to very rapid and very difficult. So we add this as another layer of progression in our therapy, and there's several studies supporting its use in ACL and as a visual training tool. So this is my last slide, and I wanted to touch on this because I think this is extremely important and it's a growing area of literature. So this has been hit on a little bit, that psychological distress plays a big role in our recovery. So about a third of our patients have fear of movement, have fear of re-injury. And I've been very disappointed. If you go into the literature, you'll probably be disappointed too. For physiotherapists, there's not many good recommendations. They're just like, well, send them to counseling, try to screen people, but it's very hard to know what can I do with my practice. And we just finished a study that looked at the neural correlates, or the neural activity associated with fear of re-injury and fear of movement. And we found this corticospinal thalamic loop increased activity. What's important is there's some studies in PTSD showing how you can modify activity of this loop. So this was found to be a similar tract in those with traumatic stress. And so there's very simple things you can do in your clinic when you prescribe your exercises. So a lot of this has to do with your locus of control. So locus of control just means, do you feel like you're in control of your exercises, or is it external to you? So athletes, they tend to be in control of their life until they get injured. And now they cede all the control to you, and to the physician, and to the medical team. And you can actually suppress activity of this region if you restore that. So there's very simple ways to do this. One is, say your patient comes in, they maybe have high fear, but I would encourage you to explore this with all your patients. You have 10 exercises that can do quadriceps weakness that you can do to strengthen the quads. Maybe you probably have 100 exercises. So list your top handful, and you tell the patient, this is what our goal today. You pick the 3 you want to do of the 10. Now, this is a very, very subtle thing to do, but you'll be shocked at how that drastically can change the neural activity for the oncoming session. Most of that data is from post-traumatic stress therapy, where they give people control in their therapy. There's no reason we can't do that in physical therapy. Another approach is to tell your patients that you're going to do this landing exercise or whatever it is you're doing, and normally we give them feedback on how they're doing. You just say, when you're ready, I'll tell you how you're moving, if you're moving well or moving poorly, and what to correct. You let them come to you, and you restore their control to them. That can be very powerful. So I've talked about how the brain changes, and I've talked about some key therapies you can implement, and I'd be happy to take, sorry, before I get there, so I owe a lot of this work to a lot of other people that I've worked with over the years. I've had a lot of exceptional collaborators and our funding sources. And with that, I'll take, I think we're doing questions at the end, but that's my email if you have other concerns. Thank you.